Good afternoon, everyone. My name is Emily Moore, and I'm a Senior Analyst for Health Transformation at the Association of State and Territorial Health Officials. I would like to welcome you to today's webinar on Project ECHO, which is entitled Using Project ECHO to Increase Access to Specialty Care, Strategies for States and Lessons Learned from Oklahoma. ASTHO is committed to supporting state and territorial health officials and their leadership teams within the transforming health system. So, with support from the CDC, is providing this webinar to facilitate the sharing of best practices and lessons learned on using Project ECHO. And so we'll learn how Project ECHO has been used in different states to enhance specialty care, describe policies and funding mechanisms needed to implement and sustain Project ECHO at the state level, and describe how Oklahoma State University is using Project ECHO and their lessons learned. In an effort to reduce background noise, we ask that you mute your individual phone or headset during the presentations and when you are not speaking. Also, please do not place this call on hold. If you have a question during this call, you are welcome to post it in the chat box on your screen at any time. These questions will be answered during the Q&A at the end of today's presentation. We will also open the phone lines during the Q&A session for you to ask additional questions. At the conclusion of the call, you will be directed to an evaluation survey. So we hope you will take a few minutes to complete this survey, as we appreciate any feedback you may have to help inform future ASTHO work. Please note that this and the recording from today's webinar will be sent to all registered participants in the next few days. Now I would like to introduce today's speakers. Mei Wa Kwong joined CCHP in March 2010, where she works on public policy issues as they impact telehealth on the state and national level. She is also the project director for the National Telehealth Policy Resource Center. For CCHP, Ms. Kwong manages projects, provides policy, technical assistance to state and federal lawmakers, industry members, and others. And she also oversees the CCH policy staff and works closely with their partners and consultants. She's authored several articles published in peer-reviewed journals and presented at national conferences on telehealth. Prior to joining CCHP, Ms. Kwong was a public policy analyst for the Children's Home Society of California, working on child care and early education issues on the state and federal levels. She also worked extensively with the Child Development Policy Institute, a statewide public policy organization. Ms. Kwong holds a BA in International Affairs from George Washington University and a JD from George Washington University Law School. Dr. Joseph Johnson is the Associate Dean of Clinical Education and Simulation Medicine at Oklahoma State University Center for Health Sciences and is currently the Chief Medical Officer for Project ECHO. Dr. Johnson received his medical degree from the University of Health Sciences, Kansas City, Missouri. He then completed a residency in obstetrics and gynecology from Michigan State University. Dr. Johnson specialized in high-tech, minimally invasive surgery before becoming Department Chair for Obstetrics and Gynecology, where he has served as Program Director for Residency Education. Dr. Johnson is now the Associate Dean for Clinical Education and Simulation Medicine. He holds the endowed chair position from George Kaiser Family Foundation in OBGYN. Dr. Johnson currently serves as Chief Medical Officer for Project ECHO, meeting the specialty care needs in rural Oklahoma. He is married with 5 children, and he has trained and trusted his residency in the delivery of his 7 of 13 grandchildren. At this time, I'll now turn it over to Mei, who will give her presentation on Project ECHO. Thank you.
Thank you, Emily, and thank you, ASTHO, for inviting me to do this presentation to you today. I've been asked to give just an overview on what is Project ECHO or ECHO itself and some of the examples that are located throughout the country and what are some of the policies around Project ECHO that exist out there. And then you'll hear about a more specific program from Dr. Johnson in Oklahoma. So just really quickly, as Emily said, I'm an attorney, so I always have to start off my presentations with a quick disclaimer here. Any information I give you today is just for informational purposes. If you're looking for a legal opinion, CCHP always recommends that you go seek out legal counsel. And also, if I happen to mention a company or show a piece of equipment or something like that, know that CCHP has absolutely no financial arrangement or interest, or neither do I, with such organization. We are either funded by grants or we have contracts for very specific types of work. Just a little bit of background on the Center for Connected Health Policy. We were actually funded with grant from the California Healthcare Foundation back in 2009, so we had a California telehealth policy specific mission. Until an opportunity became available in 2012 with a grant from HRSA to be the National Telehealth Policy Resource Center. We applied for that and we received it, and we've been serving in that capacity since. But what exactly does that mean? So what we do is underneath our grant program with the federal government, there are actually 14 of us. There are 2 national centers. We're the Center on Policy, and then there's another center based out of Alaska that focuses on the technology. So if you have questions about software and equipment, they're a great resource to tap. There's also 12 regional resource centers that serve specific states and located throughout the country. And they're sort of more program, boots on the ground type of people who can help folks who have questions about telehealth. I like to call them the front line. So any type of questions you have about telehealth, from what it is to how do I get a program started in my clinic, they're a great resource to tap. And all 14 of the resource centers work collaboratively together. So if you reach out to one of us, you're really getting all 14 of us helping you. We try to be a one-stop shop for everyone of their telehealth needs. And if one telehealth resource center doesn't know the question or the answer to a question, they can actually reach out to the other 13, and usually somebody knows it or somebody knows how to get out and find the answer to it. What we do specifically as a National Telehealth Policy Resource Center, aside from providing specific technical assistance to folks who may have questions, and we can help everybody from congressional members to a consumer and everyone in between. What we also do underneath our federal grant is that we track all the telehealth policies, laws, and regulations for all 50 states and the District of Columbia and on the federal level. That's a screenshot of our website. That's an interactive map. You just click on a state you're interested in, and it brings up all the current telehealth policies and regulations and Medicaid and laws and Medicaid policies that we found for that state. And it also provides the source link for you as well. We also track any pending legislation related to telehealth for all of the states and the District of Columbia and on the federal level. So just really quickly, I'm sure most of you know, but just for our purposes today to make sure everyone is on the same page here, there are 3 modalities. When you think of telehealth, there's usually 3 modalities associated with. There's live video, which is a real-time interaction, and it takes place between a patient and provider, or maybe even provider and provider. There's store and forward, which is not real-time. That's the capturing of some information and sending it digitally over some secure system to a provider who's in another location who won't look at it right at that moment, but will look at it at a later time and then send back their write-up on it, their thoughts on what it is. And then there's remote patient monitoring, which can be both live or asynchronous, not in real time. It's a consistent monitoring for a period of time of a patient. For a live example, think of a tele-ICU. Intensivist may not be on site, but is doing like continuous monitoring. A not live interaction can be a patient at home. Perhaps they have hypertension and they're sending in blood pressure readings to their primary care provider, who'll look at it not like in real time, but maybe will like look at a week's worth and then like get back to the patient if there's something that's concerning. What most people are familiar with using these modalities is providing the direct type of medical services to a patient or consulting with their provider one-on-one. That's kind of what most folks are familiar with when they talk about telehealth. However, telehealth can go beyond that. It can be care coordination and data collection, provision of public health information, and also it could be training and education. And that's kind of what we're focusing in on here today with ECHO. Now, what is ECHO? ECHO actually means Extension for Community Healthcare Outcomes. It was something that was started in New Mexico because a doctor, Dr. Sanjeev Arora, and I hope I'm pronouncing that right, who's with the University of New Mexico School of Medicine, noticed that there were high levels of hepatitis C that was being untreated in like rural areas because simply they couldn't get to the specialists who could help them with it. So he created something called Project ECHO, which allows specialists to be in touch with local providers. His little pilot, his idea started off, very small in New Mexico, but today there's actually more than 110 hubs for more than 55 diseases and conditions in more than 21 countries that are using this type of model and what they're trying to do. Now, he started off with hepatitis C, but this is just like sort of a very small sample list of the different type of conditions that Project ECHO is being used for. There's chronic pain management, opioid management, cardiology, endocrinology, AIDS, dementia, palliative care, and psychiatry. But as you noticed from the previous slide, there's about 55 different diseases and conditions it's being used for today. So how does it work? So basically, you have a patient who goes in and sees their primary care provider, and maybe there's not a specialist available for them to see right away. So the primary care provider sends in like the case history of the patient to a group of specialists in this Project ECHO model, who is basically sort of like a grand rounds. They will look at it and see like, you know, what their thoughts are on that particular case, and then they will interact via video, that's that second figure, with the primary care provider to like give their opinion and their thoughts on the case. And the primary care provider will take that knowledge and go and apply it to the patient. So you're really basically educating and, you know, training, I guess could be used the word, the provider in these certain cases and providing them with greater information. And you're raising them up to a higher level where, you know, if this type of case presents itself with a different patient in the future, they kind of know what to do then. It also keeps the patient in their community and working with their primary care provider. So everything is inside the community as opposed to like sending the patient to like a different location, maybe hours away for them to get their care. So it increases access, improves the quality because of the care the primary care provider is able to do, and it also reduces the cost because, again, you're not transporting that patient. A lot of the resources are staying within the community itself, and also you're not really involving the primary care provider's time and having the patient go back and forth so many times. What are some other examples of ECHO projects? So, you know, just to see like the vast ways that ECHO could be used, there's a project out of Beth Israel. It's called ECHO Age, and it uses telehealth to connect experts to clinicians in nursing homes to help improve the care for elderly patients suffering from dementia. So it could also help them, you know, adjust their medications and actually other techniques that would be able to help their patients. And, you know, in speaking with this program, you know, they noted that there's a great shortage of, like, experts with geriatric care in providing this type of service. So, you know, ECHO is a great way of, like, sort of expanding and distributing those resources to a wider area. There's also something called ECHO Autism. It's out of the Thompson Center for Autism and Neurodevelopment out of University of Missouri, and that provides services both to the providers and how to treat cases where autism presents itself. So again, you can see sort of like the wide variety where ECHO is being used. A quick rundown of some of the federal ECHO projects. You have HRSA, who uses ECHO to address autism, epilepsy, opioid disorder, and Hep B. A lot of Hep C pilots are out there. There's some with the CDC and with ARC. There's also a U.S.-Mexico Border Health Commission that uses ECHO to treat TB, and that is for both U.S. and Mexico states right along that border. Now, federal policy itself, established federal policy, is a little bit sparse around ECHO. So there's proof that ECHO works really well. There's a lot of ECHO programs out there. ECHO is present in 21 countries, but the actual established policy around ECHO is kind of sparse, both on the federal and state level. There was a recent bill that was signed into law in December of last year that required the Secretary of Health and Human Services to study ECHO and, you know, see what are sort of like the impacts it could have, and also what are some of the workforce issues around it. But there's nothing in the federal books that would actually reimburse for ECHO. It's really been grant funded up to this point, even though it's proven to have, like, you know, great utilization, great outcomes, but it hasn't really been funded on the federal level, and there's actually also very sparse policy on the state level as well. So recently, Missouri passed in 2014. There's a small ECHO mention in this bill where it requires the University of Missouri to manage an ECHO program, and there was money allocated to it in, like, the Missouri budget. But again, that was like just a very small sort of piece of legislation. It's not something that's being reimbursed in, like, Missouri Medicaid. New Mexico, the birthplace of ECHO, does have something for their managed care organizations where they have their managed care plans do some reimbursement for it, but that's very rare. You don't see that in any other states, even though there's a lot of interest around ECHO, there's a lot of evidence around ECHO. The actual established policy around it has been very lacking so far. Hopefully we'll see a change in that in the future, and it's probably with programs like Dr. Johnson is going to talk to you about next that, may help push that forward. But for right now, we really don't have a lot of policy or reimbursement around it. It's been a very grant-funded type of program so far. And that's about it, and that's my email. People have questions, but I'll turn it over now to Dr. Johnson.
Great. Well, I will unmute myself here, and hopefully you can all hear me. Mia, thank you very much. That was an excellent presentation. I mean, I don't think I have to say anything now. So I'm hoping somebody is hearing me out there.
You sound loud and clear, Dr. Johnson.
Okay,
Thank
great.
you.
Okay, so we'll go ahead and talk a little bit about then what Oklahoma State and that has actually done, and what we've looked at within our state, and how we're looking at potential for sustainability in that also in the future. And our slides moving forward. Okay, good. Again, I have no financial interest. I'm willing to accept any money to pay for those 13 grandchildren that you talked about, and we just try to talk about what we have found as far as evidence-based availability here. So in 2016, something went through to Congress actually taking a look at what the needs were, not only through rural America, but particularly a lot related to the Indian Health Services and rural needs. They stated that the major national goal for the United States was to be able to provide the resources, the processes, structure in that to enable our rural communities, tribal members in that, to obtain the same quality and quantity of care as you could in our inner city and more urban type related areas. Certainly Oklahoma State University deals a lot with rural communities. We provide a lot of education in that to those areas, and we also provide through our medical school a lot of residents that actually then go out and practice into those rural communities. I see quite a few of my colleagues actually on board here, and they can speak to some of these issues also from that standpoint. Maybe I'm not knowing how to forward things based on their things here. Great. If I say next slide, are you controlling the slides there? I'm going to take it that you are. So one of the things that Project ECHO does also is Congress was told that what we need to do is to be able to find the right provider at the right time at the right place. Well, that's actually part of the philosophy totally behind the Project ECHO movement. We realize that within the rural communities that actually the healthcare outcomes actually decreases the life expectancy about 4.5 years compared to areas within our urban areas. There are certainly higher rates for alcoholism, for obesity, for even exposure to hepatitis. We understand that there's a lot of diabetes, endocrine-related disorders, unintentional injuries into these communities. And how do we get the access to care to the rural areas that actually gives the same quality that we have in the urban areas? Next slide. So as Mia so eloquently provided, basically what we're trying to do is find how do we get the access at the time that a patient needs it? How do we find the right qualified provider that can take care of that patient and be able to provide them the right care with the right provider at the right time? And so that's kind of what Project ECHO started to deal with. Next slide. So what we did was we took a look at some of the needs throughout the state of Oklahoma, and we identified several areas that had great need. One of them was mental health related disorders, as well as the substance abuse. We are finding that there is a great amount of opioid addiction, overutilization of prescriptions. Unfortunately, even as of this past Friday, one of the physicians down in Oklahoma City was just arrested on 5 counts of overutilization of opioid drugs that led to the demise of patients. So we need to make sure that we understand what the needs are there and to provide the education to where the local point of contact physician can understand what the specialty care needs are within their communities, and then be able to have the educational wherewithal to be able to treat it within their community. Next slide. And we'll let you play this short.
I grew up in rural Oklahoma. Coweta, Oklahoma is where I call home, and I live there now with my family.
Beautiful, peaceful, home. Rural Oklahoma has much to offer, but Dr. Casey Schrum, the president of the Oklahoma State University Center for Health Sciences in Tulsa, knows there's a big problem in rural Oklahoma.
The majority of the counties in Oklahoma are considered health profession shortage areas by the federal government. So what we're seeing in rural Oklahoma is that people are not as healthy, we're not living as long, the cost of health care is higher there because we don't have access to preventative health care.
With the physician shortage in rural areas, not just Oklahoma, but across the country, you're starting to feel the pinch.
Dr. Douglas Nolan is a rural physician for the Cherokee Nation in Tahlequah, Oklahoma.
We often forget the burden on the patient. It takes their time. They have to take off work. It takes their gas, so it takes money. When you talk about some of the patients whose maybe their funds are limited, that's difficult.
Our mission at the OSU Center for Health Sciences is to provide primary care physicians for rural and underserved Oklahoma. We really believe in our pipeline programs of finding the right students and being mindful of the way we train them and training them in rural Oklahoma where we want them to practice and stay.
I'm so pleased with OSU's mission of populating rural Oklahoma with physicians that come from rural Oklahoma.
90% of the residents who are graduating from those rural residency programs are staying in the state of Oklahoma. 80% are staying in rural Oklahoma.
But it's still a constant struggle to keep primary care physicians populated all around the 14 counties.
Project ECHO is a new way of basically providing specialty care.
ECHO stands for Extension Community Health Outreach. And so it is a powerful tool that can be utilized by the university to push medical knowledge out to rural communities.
A lot of times what we need as primary care is we need a curbside consult. We need a backup.
Using advanced communication technology, OSU's ECHO, which originated at the University of New Mexico, is enhancing the medical education of healthcare providers in the rural areas, connecting them with specialists in the urban areas.
We actually have a greet and eat over a lunch hour where doctors in a local community can meet with a specialty team.
Hi, Dr. Nolan. Thank you for joining us today. Today we're going to starting with our
I can participate anywhere I am, you know, with today's technology, with cell phones, through the computers, through the laptop.
ECHO addresses the physician shortage by making specialty medical knowledge from the urban academic centers more easily available to primary care doctors in rural areas. Community healthcare providers learn from the specialists, essentially flipping the access to care model by moving medical knowledge to the rural doctors, not patients to the urban doctors.
They provide a lecture once a week, so what it actually does is it gives me education on various subjects, brings me up to date.
We start out with the academic center actually being the hub. We have all of our specialists on team with us as physicians of Oklahoma State University.
We can treat a lot of the patients in the rural area just by sharing the knowledge that OSU is providing.
We identified 5 major areas to get started: mental health, addiction, HIV and hepatitis C, obesity within children, and pregnancy care.
Project ECHO is a way really to help support physicians who are already practicing in those communities and give them all the knowledge and skills that they need without requiring them to leave.
Oklahoma State's filling a void here for the state of Oklahoma that it is going to be a tremendous boom for the rural areas.
Providing primary care physicians and increasing access will improve the health and vitality of our communities in our state. I grew up in rural Oklahoma. My values and my upbringing were there. I embrace that lifestyle, and I truly want my family and future generations to be able to enjoy rural Oklahoma and agriculture.
Okay, thank you everyone, and for bearing with us during those technical difficulties. We'll hand it back to Dr. Johnson to sum up his presentation and finish it. Thank you. And also, before I do turn it over, we've included the YouTube link so you can view the video at your leisure after the webinar as well. And we'll be sure to include that in any follow-up messaging. All right, on to you, Dr. Johnson.
Okay, great. Well, I'm sorry again about that technical glitching on the system here. We do, throughout the entire ECHO program, we use a different type of a platform called the Zoom platform. The Zoom platform does allow us to have up to about 200 potential participants. Of course, what we try to do is make our groupings a little bit more family focused. So we try to get those rural doctors to enter an ECHO line that they find of interest, to where they kind of become the specialist within their local community. Our third and fourth year medical students that are actually going out into these communities have also helped get some of those doctors involved when they start talking about problems that they have, that they want to refer those patients into the academic center. This way they give that training to those local doctors by joining an ECHO session. It is not required that you be a physician also to join an ECHO session. We realize that there are a lot of community-based providers that may be nurse practitioners, physician assistants, people from the social work line that really just need some of these resources that our Health Access Network as well as our physicians can provide them. Certainly the ECHO line is totally free. Anybody that actually attends an ECHO session, it does not cost them anything. We provide them with the education that they can improve into their communities with, and they do get some free CME from that standpoint. Next slide. Certainly, we already mentioned that there is a lack of certain specialists within rural Oklahoma. Mental health disorders are constantly being referred in. Childhood obesity, we feel that if we can change the aspect of childhood obesity moving into adult obesity, that it will also take care of some of those correctable problems that we see in adulthood: diabetes, hypertension, coronary vascular disease, etc. Transportation, housing, crime seems to be a problem. We have identified that we probably need to start an ECHO line in correctional medicine, and that's one of the areas that we're looking for in the future. Next slide. It does use a regular teleeducation type application where we go to those areas of cognitive knowledge and then moving them on to the either psychomotor skills or affective areas that they need to improve those community outcomes. So if we can get a local provider to remember what it was like back in medical school and in residency when they did these grand round type sessions, to where we can provide them with a guided practice, it improves those patient outcomes because they then become the specialist within their own community. Next slide. So this really is related to teleeducation or telesimulation. The big portion in learning is related to the debriefing portion. So through a physician in a rural area presenting his patient to a group of specialists, he then learns what it is that they would do if they sent the patient directly to them. In the same aspect, those individuals that are attending the ECHO sessions learn through time. We have found that there is a definite multiplication effect that then occurs by doing that. Next slide. So what we did was we looked at how ECHO has actually started to impact healthcare and impact it fast. Next slide. The way that ECHO works is it takes a look at where the experts are, where the access to patient care is, and where the community physician is, and where all those areas actually make a way to the center is where ECHO can be utilized the most. It affects the assessment of the learners on that off-location site through this type of guided practice. Next slide. And it really is a training type skill, where telemedicine actually has the physician taking care of the patient directly. Where tele-ECHO does is it provides the physician the education to take care of multiple patients. There really is a multiplication effect there than that actually occurs. We find for every ECHO session that a physician actually is invited to will affect about 7 patients over the course of the next week in his practice. Next slide. Through our Rural Health Organization, I see Deanna Wheeler on and Chad Langriff on line. They have actually taken a look at where all the extension campuses are that are related to Oklahoma State University. We have people that are invited in our sessions that are from outside of our state as well as within our state. And we have had providers that have been out as far as Guyman all the way down into Durant. So, I mean, we really do hit the state as far as providers that are willing to participate, join into the sessions, and learn from the sessions. Next slide. So we use this hub and spoke type of a framework where the hub site of Project ECHO is the academic center. We put specialists on each ECHO line based on the needs of the specialty knowledge that needs to be trained. So in our psychiatry ECHO, we have a psychiatrist, a psychologist, we have somebody from our health access network, we have a pharmacist, and so what we do is we hit those rural hospitals, community workers, rural physicians, social workers, anybody that has that need where we can exponentially increase the knowledge for the workforce that is located in the local community. We base this totally on best case practices. So the information that is going to the doctors are basically cutting edge, and they learn from a provider that is going to cover them over the way that they practice with their patients. It really does decrease the healthcare disparities as far as access by being able to perform it that way. Next slide. So here's a picture of a specialty team. It all runs through a Zoom-related platform. They can access it through their multiple different areas of media. Next slide. So we can see that you can have up to 150 participating sites. Next slide. It works the way that Mei Kwong had told you, where the clinicians actually access through the various teleports that they have available to them. Next slide. I went ahead and tried to prove this myself, and I took my motorhome all the way up to the Minnesota border, and I accessed it off of my cell phone. And it works, it's perfect. As long as they have at least a 4G access into their community, they can get both audio as well as video as to what's going on. Next slide. The benefits, again, is they obtain the knowledge from the specialist. They do get free CME for participating into the program. It does advance their knowledge on how they take care of their patients locally, and they do get the engagement of a whole specialty collaborative team for their patient care. The thing that's kind of cool about ECHO is it's totally de-identified. I have no idea who the patient is. We're very protective over the information that is allowed to go over the Zoom platform. We don't have any identifying features that are there. And that patient is given a unique ECHO ID number to where if that physician does put the recommendations into place, he can then come back and represent that patient where we have all of that information and we can get an update on what's going on, as well as to be able to make more recommendations based on current outcomes that are occurring. Next slide. So individualized guided practice is what occurs. Next slide. We did get federal support from the standpoint that they do recognize this. As was mentioned, Senate Bill 2378 has been approved to look into this educational model as far as its effectiveness. There are multiple journal outcomes that have been published, not only with the CDC, but the New England Journal of Medicine, showing that the capacity of this really does improve healthcare outcomes and decreases dollars. Now the next step is to get local states, Medicare, Medicaid type programs to co-sponsor bills to be able to find sustainability with financial support. Oklahoma State has identified ECHO and a Rural Health Care Day. That was announced on April the 12th of 2017. And we are hoping that as we move into the future, that we'll be able to get them to appropriate a certain amount of money to be able to place it into ECHO-related programs. As Mei had already mentioned, most of this has been funded either through direct universities looking at this as part of their educational mission, or to reach outside businesses or philanthropy type dollars that have supported us. Recently, we received a $1.8 million grant through the THRU Foundation, particularly to look at addiction and mental health disorders. Next slide. This is what an ECHO session looks like, where participants from wherever they're at can join the specialty team. Next slide. One of the things that we're noticing as we're talking to our outlying areas are the areas that we need to go into. So our mental health and our addiction medicine are up and going very well. Our childhood obesity is up and going. We're getting ready to open up our HIV. Hepatitis C has been running through Cherokee Nation with Dr. Mara down there. We feel that there is a need for correctional medicine. We do see a need with high-risk pregnancy or prevention of pregnancy with long-acting reversible contraception education. And so we will be opening a woman's health or high-risk pregnancy associated ECHO. We have one of the greatest or finest hospital administration programs in the country. It's listed as number 5 for our master's degree. We plan on having Dr. Hess open up a hospital administration ECHO line to help these hospitals and rural type clinics be able to stay open and understand what's going on. I think there are certainly areas for collaboration among multiple states and funding sources that we all need to basically work together to put the pieces of this puzzle in the proper place. Next slide. We can be reached at echo.okstate.edu if you're interested in seeing how an ECHO session runs. We'd be happy to invite you to one of those. And that's the end of my presentation. I'll open it up for questions, and I thank you very kindly.
Thank you, Dr. Johnson, for your presentation. We'll transition to some questions and answers. Anybody want to share any questions? I invite you to unmute your lines and ask directly into your phone. All right. Well, while we wait for others to come up with questions, let me pose one to our presenters. Dr. Johnson and Mei, could you sort of describe how Project ECHO either aligns or differs from other telehealth activities in states such as e-consult programs?
Well, what I like to say is, again, when we're looking at teleconsultation or telemedicine, it is a provider dealing directly with either a patient or another provider in consultation. Tele-ECHO, I really look at this as being more of a tele-education through guided practice. It's more like being back as a resident or going through grand rounds, where a case is presented to a specialty board, they come up with recommendations, they send it directly back to the provider. He either puts it into effect with that patient or he doesn't, but all of the other participants within the ECHO program get to learn from the vast experiences of a specialist.
So, yeah, Emily, I'm just going to echo what Dr. Johnson said. A lot of the policy around telehealth, as I mentioned in my presentation, has been more on the provision of services. When you talk about something like e-consult, it's between two providers. So it's not sort of that setting that Dr. Johnson described where it's more of a grand rounds. It is like provider to provider on a specific case there. So there's that difference with e-consult and Project ECHO for that.
Thank you. So I was wondering if, Dr. Johnson, you can sort of expand a little bit more about the Project ECHO for opioid misuse or substance abuse. I think that's a very timely topic, particularly for public health right now. I'm interested if you've heard of other Project ECHOs in that topic or arena.
There are several that are in the area of addiction. I think when we start looking at prescription writing across this country, we have noticed that there is a far too great number of opioid-related prescriptions that are being written where addiction then occurs. A lot of these patients never anticipated being into this situation, but because of a back injury or whatever, they end up getting addicted to some form of a narcotic-type medication. There have been several ECHO lines that are going on, not only for local providers to learn how to get patients off, but to also improve the utilization of physicians that can be dealing with buprenorphine or other programs to stop the addiction. Part of that has to be in-person education to get some of those certifications, but then the rest of it can be handled through the ECHO guided practice model.
Great, thank you. Let's turn to a question we received in our chat box. With the OSU ECHO topic areas currently ongoing, are there any health outcome measures being tracked to see how rural providers are improving their patients' health outcomes through their access to ECHO? And if so, how is this evaluation being done?
We're certainly just in the nuances on this from the standpoint that I cannot give you total data outcomes yet because we just started our Oklahoma State projects in December. So the current data that we have is taking a look at our numbers in comparison to what we're finding through more national programs that have gone through University of New Mexico. Some of the areas that we look at as far as tracking is how many people are attending ECHO sessions and how many patients are they currently seeing within their communities. We know what the normal fees are for specialty care, and we can actually, by providing that, we save about $118 in specialty care. We take a look at transportation of where they would need to come to Oklahoma City or Tulsa to see a specialist, and we know what the fees are related to transportation, to per diems, to overnight stays, to what it's costing an individual to take time off of work, as well as what it costs for a regular office visit for those. For a normal individual that's going to a specialist, we know that there is about a $1,943 savings in cost per patient for 4 visits of care related to that particular problem, whether it be mental health, addiction, obesity, hypertension, coronary vascular, or whatever. Based on those predictions, currently what we're seeing through the ECHO model, that there for Oklahoma, we figured that there will be somewhere in the neighborhood of a $7.5 million savings that occurs over 3 years based on the current ECHO lines that we have going. Now it's being able to prove that as we move forward within those 3 years for those areas.
Thank you, Dr. Johnson. We have another question from the chat box directed for your presentation, and I'm going to the map to help you here. It says you showed the map of all the endpoints for Project ECHO in Oklahoma. Is there any particular part of the state that you're looking to see more involvement in the sessions, or could you talk a little bit about that?
Absolutely. There's several different areas that we're looking at. obviously OSU has a couple of different pillars of excellence that we deal with, and one of them is with our iMedicine associated with our tribal nations. And so we have lots of areas that are associated with the different nations across Oklahoma. Currently, we're looking at a large expansion into the Tahlequah Cherokee Nation. We're starting an extension of a medical school down there in 2020. And so, yeah, I mean, we're focusing where we have our health access network to where we can then provide multiple services besides just private Project ECHO in those communities.
Thank you. Did anybody else on the call have any questions for Dr. Johnson or Mei? I invite you to open up your phone line and speak directly to the group. So this is Emily Moore again. Let me ask another question. Dr. Johnson, you mentioned women's health and particularly around pregnancy outcomes or high-risk pregnancy for long-acting reversible contraception. I know that many state public health departments and others are interested in increasing access to LARCs, particularly given their effectiveness. For that, how do you see Project ECHO sort of aligning with in-person trainings, particularly for device placement and the like?
I would normally turn this over to Tara because Tara has been working throughout the state and working on her PhD in public health policy related to long-acting reversible contraception. Currently, what we're finding is while we have seen some decrease in pregnancy rates, particularly in our teenage and under college age individuals in our urban areas, we have not seen that happening in the rural areas. We find that that's mainly because the providers don't have the understanding of the long-acting reversible contraception. How do you deal with it? Well, it has to be a two-part. It has to be an educational portion that occurs with guided type practice, but the other portion of it is actually having to make road trips to actually teach the various providers how to do the insertions appropriately. And that includes all of the LARC devices, whether we're looking at IUDs, Implanon, Nexplanon, or any of the long-acting rod type medications.
I think they could do demonstrations over it as ECHO and do case presentations on difficult insertions, things that occurred. This is Tara, by the way.
Oh, great. Thank you, Dr. Johnson and Tara. And is that specifically for LARCs in general, or is it also including immediately postpartum?
I'll tell you, now you're going to get me on my platform, and I'm going to go ahead and put it out there because unfortunately, the state of Oklahoma is finding that more and more of our hospitals are coming under the guidance of religious-based institutions, meaning Catholic organizations that are taking over control of a lot of our hospital systems where they're not allowing immediate access to these devices for birth control. I think that's going to have to come through legislative efforts to be able to say, hey, if you're taking federal-related dollars, then you provide the care for all federal-related dollars entails, which would be immediate post-delivery insertions, the ability to write for or give depot injections. That's a trickier thing, but I can get off my soapbox and say I think it's going to require legislative effort on a state level, at least in Oklahoma.
Thank you, Dr. Johnson. We can certainly appreciate how those factors align, and perhaps if not to get in our soapbox, but we do have resources for states on our LARC learning community if you're so interested. And for others in the call, it's not specifically related to telehealth, but I did want to put that out there. I had question for the group. So, Dr. Johnson, what advice would you give to another academic medical center about how to create a Project ECHO? Is there anything that you wish you would have known in advance? I know the model has been used a number of places, but curious if you have advice for those who'd be interested in that.
Absolutely. I think if we take a look at what has happened nationally with Project ECHO, is for not the academic center to say, this is what I want to do. Because I'm going to give you an example. University of Illinois, Chicago, had some phenomenal specialists that said, we're going to start an ECHO program because I've got all of this knowledge base here at my institution and I'm going to force it out into the communities. Well, the communities didn't need it. They did not have that great of a need for those specialists as much as what they felt there was the need out there. So I say it's based on what you find within your system. I am very fortunate that I've got Dr. Deanna Wheeler on my team that handles all of our rural statistics, does all of our community outreaches within our counties, looks at all of the hospital-related needs, and can tabulate for me what are the greatest needs that hospitals are sending patients to Tulsa and Oklahoma City for. Based on that, we decided what ECHO lines we would open. So what we are doing is we are meeting the need that is already in existence, not trying to create a need and find people to fill it.
Great, thank you. And Mei, I did want to ask, based on your work with other states in telehealth, do you have any advice for those around Project ECHO?
Well, I think Project ECHO is kind of just facing the same issues that any telehealth policies are facing. It's something that the policymakers sometimes have a hard time grasping, like with the concept of telehealth itself, in that, oh, you know, how can this work when they're not touching the patient, or how does this fit in and improve patient care? So I think it's just going to be a matter of time. Now, the nice thing about ECHO is that there have been so many programs, and there has been a lot of research written around it, where I think there will be, you know, more advancements over the next couple of years on the policy front in improving sort of the environment where you can have more ECHO programs and they can be sustainable. It's not quite there, sort of the way that, you know, telehealth isn't quite there, although there is some reimbursement for telehealth services. But it's just going to be a matter of time where things, I think, tip, and then you'll see a little bit more opening of policies and acceptance of things like Project ECHO and eventually eConsult and wider use of telehealth in general.
Great, thank you, Dr. Johnson and Mei. That's really helpful advice. I'll open it back up to the group and see if there's any other last burning questions for our speakers and their colleagues here today. All right, well, without further ado, we'll let you get back to your days. And so at this time, we'll end Q&A.
Well, for my side, I'd certainly like to thank Mia for being here. She's added a lot of wisdom from the policy and legal aspect. I'm very impressed with how much you knew about this, and I thank you for participating.
Well, thank you, Dr. Johnson. I really enjoyed hearing about your programs. I always love hearing, because on the policy level, sometimes we're a little bit removed. I love hearing what is actually being done on the ground and for patients directly. So thank you, and thank you for all the work you and your team have done, too.
Well, and one other thing I can say is for every ECHO line, it runs the university about $250,000. So you need to look at, you're going to invest your time, you're going to invest your effort, you're going to invest your money. That's about what it's going to cost per ECHO line that you start.
That is very good information to know. I did not know that it was that amount, so thank you.
Great. Well, thank you again both for your presentations. We certainly enjoyed them. And thank you all for those on the call for joining us today. You'll be After you close this window, you'll be directed to an evaluation at the conclusion of this webinar. If you could take a few minutes to complete our survey, that would be really helpful. And thank you again for your presentations, and to Ms. Jennifer Kelbach for her leadership and help organizing this webinar as well. Thank you, and have a wonderful day. Bye-bye.
Bye-bye.